Start that now. All right, so we're going to cover Chapter 18 first. We'll talk about the GI and urologic emergencies. So, as always, the National EMS Education Standard Competencies on Medicine, basically trying to find and assess the findings, what we do find for the acutely ill patients. And then we start talking about abdominal and gastrointestinal disorders. We get a lot of abdominal pain calls. These are one of the three things that we get a lot of, and no, trauma is not one of them. We see a lot of chest pain, shortness of breath, and abdominal pain. Those are kind of the three big things that we see in EMS, are those three. Followed by, lately, within the last couple of years, I've seen a big uptick in psychological or psychiatric, which is the chapter we're going to be covering after this one here. So we're going to talk about the anatomy and presentations and management of shock associated with abdominal emergencies. We're looking at the GI bleed or gastrointestinal bleeding. We're going to look at the A&P and pathophys assessment and management of acute and chronic gastrointestinal hemorrhage, peritonitis, ulcerative diseases as well. We're going to look at the GI and renal stuff, looking at blood pressure assessment in the hemodialysis patient. And for those who were involved in a lot of the transfer field, not for us up north, but Action Ambulance, we're using during your ride time, they do a lot of dialysis runs for the hemodialysis, stuff like that. But you may run into contact with some of these patients in the field. And then we'll cover more about that and how to assess them. Anatomy and physiology and pathophysiology assessment and management of complications related to renal dialysis, urinary catheter management, not insertion. So you guys do not have to put caths in males or females. It's not our job to do that in the field, but we do need to know how to manage that. And I have some interesting stories behind that as well to share with you guys. And then also the management of kidney stones. Very, very common thing for pain. When we start talking about retroperitoneal pain. So abdominal pain is a common complaint. We get that a lot, like I mentioned. One of the three things we see: chest pain, shortness of breath, and we see abdominal pain a lot. So causes of abdominal pain are really often difficult to determine. So as an EMT, you do not need to determine the exact cause. You should be able to recognize a life-threatening problem, then act upon a life-threatening problem. Abdominal pain can be a lot of things, especially from male to female. Because unexplained abdominal pain in a female within childbearing years could be an ectopic pregnancy. As long as we ask them the appropriate questions about, are you sexually active? When was your last menstrual cycle? These are some things that, especially with a lot of new EMTs, especially the male EMTs, that they have a hard time actually talking with females about this. Just keep in mind that we are professionals. We have a job that has to be done. So we need to ask them the appropriate questions to get the appropriate assessment and treatment for the patient. So again, we're not going to determine the exact cause. We need to figure out how to find the life-threatening problem, then how we're going to treat that life-threatening problem that's there. With that, the abdominal cavity with A&P contains the gastrointestinal system. We have the small intestines, large intestines, the stomach. We'll keep going through all that in a few minutes. The genital system, and then the urinary system. With this, it's made up of solid and hollow organs. We have both of those made up inside of us, which I'm going to cover that in a second in a picture as well. So the solid organs that we have are the liver, the spleen, the pancreas, the kidneys, and the ovaries for females. And injuries to a solid organ can cause shock and or bleeding. And they can bleed a lot. So we got to be able to recognize the signs and symptoms of these and get these patients to a trauma center that can do surgical interventions to help stop these bleeds. Our hollow organs, like our gallbladder, our stomach, our small and large intestines, and our urinary bladder as well. So any kind of breach of a hollow organ causes its contents to leak and contaminate the abdominal cavity. So if we have a breach, or if we have like a traumatic injury, where we have like a laceration of a hollow organ, the stuff that's inside of that gets into the abdominal cavity and can cause some significant infection with this, and also significant bleeding as well. These are the patients that go to the ERs and they get fast scans done on the abdomen, look for any kind of free fluids floating around. These patients you'll find like with abdominal distension, tenderness, palpation being very hard to the touch because they're building up so much fluid in the abdominal cavity that it has nowhere really to go. And people can bleed out and die just from this alone. So we got to keep this kind of stuff in mind when we're doing our abdominal assessment, which we'll get into in a little bit. So looking at our solid versus hollow organs, if you notice how you have the liver, the spleen, the pancreas, kidneys, and ovaries. So if you have let's say a female patient that has ovarian cysts or some ovarian pain, they're going to have that more towards the groin area, going up towards the pelvis. And it'll be a significant pain as well. These patients may be better off getting ALS en route to give pain management as far as narcotic use, using some kind of controlled substance to help with that. Kidneys are located retroperitoneal to the peritoneum. So if you reach around towards your spine and go to the left and right side of the spine and your back, lower part of your back, that's retroperitoneal area where your kidneys are located. So if we're doing like a kidney stone assessment, we're going to palpate each side, and usually they'll have a significant pain on one side versus the other as you push on it, what they call rebound tenderness, as you push down, it comes back and it hurts really bad. And that pain will then radiate down into the groin and can also cause significant pain during urination. So other questions to be asking as well. Obviously, we have our pancreas located more towards the center of the abdomen, and our spleen will be located on the left side, and then underneath on the right side will be located with our liver. To palpate the liver, what you want to do is you take your hands, you want to find the rib cage, you take your hand and you kind of place it around the ribs. Have the patient take a deep breath in, and as they exhale, take your fingers, push them underneath the rib cage, and you should be able to feel about 3 to 4 centimeters of that liver. If you can feel more than that, then you have an inflamed liver, and that could become more of a problem as well. And then a kind of interesting fact about liver failure, we should rephrase that before we get to that part there. If we have issues with the liver, we'll tend to see the skin of a patient and the eyes of the patient, the whites start turning yellow, or jaundice would be the name for that. One of the leading indicators in a pediatric who's got congestive heart failure or CHF new onset is going to be an inflamed liver. So we want to actually do good assessments as we're doing that. And I'll get that more into pediatrics. On the other side, obviously, we have the small and large intestines, the fallopian tube, and be familiar with that as well, because that's one of the most common areas that we're going to find in ectopic pregnancy. Usually that the seed has been planted in the fallopian tube itself and starts to develop at that point. We have the urinary bladder, we have the uterus that's located down lower, our stomach, and then our gallbladder. So sometimes we'll have patients that have significant chest pain. They say, oh, it's a burning sensation right in my chest, right? And it gets worse when I eat different foods, more like towards fatty foods and things like that. They could be having a gallbladder attack and may need to have their gallbladder removed. No, we don't remove those in the field, as fun as it could be. We don't take those out. But it can also mimic that cardiac chest pain that they actually see. So that's between the solid and hollow organs. Let's go to the next one here. So with the gastrointestinal system, it is responsible for the digestion process. So what happens is digestion begins when food is chewed. The saliva breaks it down and food is swallowed, goes down the esophagus into the stomach. The stomach is the main digestive organ. Inside of that, they have a lot of acids that break down this food to start the digestion, to push it through the large intestines into the small intestines to be able to excrete that back out. And prior to that, it's taking all the nutrients and it's going to the body for energy. As part of this, the liver then assists in digestion as well, which secretes a bile and the acids and digestion of the fats that are there. And they filter the toxic substances and create glucose stores that help produce energy to let you function throughout the day. The gallbladder is a reservoir for that bile, but a lot of times they can have inflammation with that gallbladder, causing significant pain and discomfort. Another thing about the liver as well is also what they call the first pass effect, and the first pass effect is utilized when we're taking medications and administering meds. So if we're giving somebody anything oral and EMT level, giving like PO Tylenol or PO ibuprofen, the first pass effect of that's going to hit the liver and start pushing that out from there. So if patients have liver disease or they're alcoholics to the point where they destroy their liver and causing liver disease like that, or they're very jaundiced, we just got to be careful of the medications that we're giving them because the liver is not there to help produce that and or help with the digestion. The small intestines, we have different parts. We have the jejunum and the duodenum. The duodenum is the digestive juices from the pancreas and liver. They start mixing at that point. The pancreas then releases amylase, bicarbonate, and insulin. So as you can see, pancreas helps out with the endocrine system. So as we're releasing the insulin, we're dropping our sugars, helps with the breakdown of the sugars there as well. And then they have the jejunum, which absorbs the digestive products that are there and does most of the work. So we can have an understanding where the small intestines are located versus the large intestines. There are times where we actually have different blockages and things like that. We'll talk about small bowel and large bowel obstructions here in a little bit. The ileum absorbs nutrients that were not absorbed from earlier, and they absorb the bile acids so that they can be returned to the liver for future use, and vitamin B12 for making nerve cells and red blood cells. So as you can see, it's very important having the gastrointestinal system intact as we're trying to keep the process going for red blood cells to circulate. Remember, red blood cells carry oxygen, and we also need to help with the nerve cells to help with pain and things like that. It's just through transmission. And then we have the large intestines, which is the colon. So with that, food that is not broken down comes here. This helps peristalsis. So what is happening here with peristalsis is it moves waste through the intestines, pushing through. Water gets absorbed through osmosis, and that's how the stool is formed. So if we have a patient who has diarrhea, okay, food is coming through, we're having an abundance of absorbed water coming through the intestines, large intestines, causing that to liquefy even more. And then the diarrhea obviously can deplete the fluid volume that we have within the system, and by doing so can also cause significant dehydration. So that's why we got to watch for the kids that have this kind of stuff, or like a gastroenteritis type deal, where our gastrointestinal tract has an inflammation or an infection of some sort, therefore absorbing more water, dehydrating the patient, and causing more diarrhea. So as you can see, just a patient having diarrhea can actually cause patients to have lower blood pressures and things like that. So we got to look for that, looking at our vital signs and our trending in our vital signs and asking the appropriate questions as well. So if they are having diarrhea, was it truly liquid? Was it a soft stool? Was it a hard stool? They're not absorbing enough water. And one of the things looking at the digestive system with the colon, if water is not being absorbed enough, what kind of medications are they taking? And a lot of times you'll find patients that have, let's say, a blockage somewhere. If they've been taking narcotics for pain or pain meds, a lot of times that can actually make the feces even harder, the stool harder, to the point where they actually have those blockages, to the point where they actually have to have digital impactation done. That's when a physician, not a paramedic or an EMT, physician goes in with fingers and starts pulling out that blockage. And I've been, unfortunately, have been part of this and assisting the physicians with this kind of stuff. And it comes out almost like a hard clay, and it just crumples in your hand. So that blockage is there. Keep in mind that it can also cause a lot of damage to the colon coming out if it is actually that blocked. And that's where they start doing enemas and things like that. And one of the best enemas I've ever had to use on a patient would be, it has to be whole milk and molasses. You mix them together, warm them up, and then you put them into an enema bottle and you squeeze it in. Usually within 5 minutes, it's usually breaking up the hard stool that's there. So if you guys are eating dinner right now, I do apologize for some of the graphic discussions we're having, but welcome to EMS. So the spleen, located in the abdomen, has no digestive function whatsoever, but it is part of the lymphatic system. So the lymphatic system is actually very important to us. So in some of the diagrams, that would be the green blood flow green flow that we see on some of the pictures that we see in our books. This assists in filtering the blood, develops red blood cells. It's also a blood reservoir, and it also helps produce antibodies. So you can see how the spleen is very important to us. The male reproductive system, for the genital system, we have the testicles, the epididymis. Some of these words I may not be able to pronounce. So the vasa deferentia, seminal vesicles, prostate gland, and the penis, all part of the male reproductive system.
Kevin, I had a quick question.
Yeah, should we go back to the slide, or are we good here?
No, well, it's about the spleen. Yeah, you said that it assists in developing red blood cells. Is that the only place that red blood cells are developed?
So the spleen assists in that and develops those red blood cells. So yes. So I'm going to say yes, it's part of the lymphatic system. The lymphatic system is helping develop those red blood cells, and then what happens is they go out into the bloodstream, and the lymphatic system helps remove that bad waste. Okay, not like carbon dioxide, which is exchanged in the lungs. The rest of the waste through the blood and everything else, the filtration goes through that lymphatic system. So the spleen is developing those red blood cells to kind of go back into the bloodstream. Does that make sense?
Yes. Yep.
All right. So things about the male reproductive system you need to understand as well, and keep in mind, and this goes back into some of the sepsis stuff or the bacteremia. So if you have a patient who has like a high fever, they have very cloudy urination, that's when we need to ask these patients doing these assessments. When you do urinate, does it burn when you pee? And if you do see your urine, is it very cloudy? What color is it? So obviously the female has a smaller urethra versus a male, which is why we see more females that are more prone to urinary tract infections than males are. However, males can get urinary tract infections causing what they call a urosepsis. So think of uro in the urinary system, urinary tract, having an infection just located in the kidneys or the bladder itself. Something to keep in mind is that males can get uroseptic and or UTIs, especially if they're doing catheterizations at home. And we're starting to see a lot more of urinary catheters being placed at home by traveling nurses or home aides that come in, or they do self-caths as well. So we'll get more into the urinary stuff later on. But again, if you have a patient who's at altered mental status and you think potentially it could be an infection of some sort, and they're a little hypotensive and they have a fever or the little tachycardia, one of the things you can ask is, do you have a urinary catheter? And if he does, when was the last time it was changed out? And then if they have a urinary catheter bag, look at the bag of urine that's actually there and see what color it is. It could be full of blood clots. It could be red. It could be orangish, yellow. What we want to look for is that clear, that little small yellow tint. That's what we're looking for normal urine. And you can usually tell, yeah, that looks like a UTI. And then they'll get tested and find out through a urine analysis. The female reproductive system has ovaries and fallopian tubes, uterus, cervix, and the vagina. Keep in mind this helps reproduction with that as well. We'll get into that stuff here in a little bit. And we'll do more when we talk about obstetrics. I don't want to go too in detail yet. So the urinary system controls discharge of waste materials filtered from the body by the kidneys. There are two kidneys, one on each side of the body. They lie on the posterior wall of the abdomen, which would make it retroperitoneal. They regulate acidity and blood pressure. They rid the body of toxic waste, and blood flow is very high in the kidney area. So if we have kidney injuries, We can lose a lot of blood quickly with that. The kidneys, remember, they are very important to us. They help with filtration. The filtration goes through ascending and descending loops within the kidney. There's nephrons within the kidney that help with that filtration system. And there's different tests that they can utilize to kind of assist with that, with the urination. So another thing to also consider is asking a patient when they're on medications as well, what are the medications we're looking for are any kind of diuretic. So one of the major diuretics that we see out there would be something like furosemide or Lasix. And this helps stimulate the ascending and descending loop within the nephron in the kidneys. All right, so it's a loop stimulator, so what they call a loop diuretic. The problem with people taking Lasix is that it's a non-potassium sparing diuretic, so which means that it'll piss out all the potassium and your body won't have enough time to kind of replenish that. And because you have low potassium, it can cause a lot of rhythm changes or more of an arrhythmia within the heart. So that can cause patients to actually have some chest pain. It can cause them to have syncopal episodes because their potassium is so low. So as you can see, looking at the A&P here and the urinary system and what's actually going on within the kidneys, there's medications that stimulate these things that patients take on a regular basis. So we got to pay attention in our assessment, looking at that as a whole. What medications do you take? And one of the indications you would find a patient to be on a loop diuretic like that would be swelling of the legs or looking at edema, or if they have a history of congestive heart failure. Because now we have backup of fluids coming from, if we have extremity edema, backup of fluids coming from the right side of the heart, so backing up through the right atria back into the body, causing the edema that we have. So what happens with the Lasix, it takes that fluid that's there and pushes it out of the system into the kidney, causing more urine, which is why patients that are on like hydrochlorothiazide and things like that as well will actually cause patients to pee a lot more. So again, if there's a blockage somewhere, that could be a big issue. The ureters join each kidney to the bladder. So the bladder is located behind the pubic symphysis. So when we're palpating, we want to palpate below the umbilical area, the belly button, go below that, and we can actually push and feel the bladder. A lot of times there'll be extreme pain, especially if they have a blockage, which can happen. That's why people put Foley catheters in to help with that, because they can no longer urinate or they have a temporary blockage as well. The bladder empties urine outside the body through the urethra as they pee it out. On an average per day, they should be urinating 1.5 to 2 liters urine per day. So the magic number to consider if you're trying to figure certain things out, how much urine comes out, it's 30 mLs an hour is the average amount of urine that should be urinating per hour. If we're not seeing that, then we have urinary issues. Why are they retaining urinary retention? And that can cause significant abdominal pain. And there are some medications that are out there, if they have certain procedures done, that can actually cause these patients to not be able to urinate. And then I've seen this a lot. We don't see this much in the ambulances. I saw this working in the emergency department, where we see patients come in all the time that have urinary retention. So literally, I would just put a Foley catheter in, and they'd be like, "Oh, it feels so much better." Then we have to send them to urology to find out why they were blocked. But again, if they can't urinate, it causes a lot of distension to the point where you have to train yourself on how to pee again at some point in time in the future, because your body forgets how to urinate. That's why people get Foley catheters placed all the time as well. So looking at the urinary system here, this is the male urinary system. So, as you can see the kidneys, and you see the 2 ureters going to the bladder, right? So we're filtrating through the kidneys, we're pushing that toxic waste, urine, goes down into the bladder where the urine is stored. When you're ready to urinate, you see the ureter openings there. We start pushing the urine out through the urethra, through the penis, to the external urethral opening, and that's how we can urinate. So pretty simple, but if you can see my mouse on the screen here, we got to watch for kidney injuries. So if you have patients that have fallen, people that get into fights and get kidney punched, even motor vehicle accidents, if we have significant pain one side or the other, we need to start checking blood pressures immediately and make this a critical patient every 5 minutes for blood pressures. Because remember, the kidneys store a lot of blood, and we can lose a lot of blood that way. The body can survive on one kidney if a kidney gets removed as well. You just got to be careful for infection. When we talk about kidney stones, what's happening here is the ureter comes out, your kidney builds up calcified deposits in here. And what's happening is trying to fit through into the ureter and pass. But the stone is so big that it's causing a lot of significant irritation trying to pass through, that it causes significant pain. So even something like a 4 millimeter stone can take some massive bodybuilder who can bench press 500 pounds and drop them to their knees, a 5 millimeter stone, because that is so painful at that point. And this is what we call renal colic. And with renal colic, the best medicine for that, other than giving them narcotics, is something called ketorolac or Toradol. And it's something that can be given at the paramedic level to help reduce inflammation. It's kind of like an IV NSAID. This is very powerful. And this works really well in conjunction with a narcotic. So a little pathophysiology behind this. So the abdominal cavity is lined by the peritoneum. This also covers the abdominal organs. The parietal peritoneum lines the walls of the abdominal cavity. Then we have our visceral peritoneum, which covers the organs. Foreign materials such as blood, pus, or bile can irritate the peritoneum, causing a peritonitis. So to kind of break down, perito would be the peritoneum. Anything that ends in itis or itis is inflammation. So if you've heard a lot of things that are out there that end in itis, that means they're talking about inflammation, like laryngitis would be inflammation of the larynx. So just kind of keep that kind of stuff in mind if you're looking at different assessments and people telling you different things about themselves if they've had any kind of inflammation or kind of infection. The acute abdomen refers to onset of abdominal pain, the sudden onset. So if I'm sitting here, all of a sudden I have significant abdominal pain. That's an acute abdominal issue or acute abdomen. So anything with acute would be sudden onset, often associated with severe progressive problems. So I'll cover more of the assessment here in a little bit. We talk about how to assess these patients with the abdominal issue. Peritonitis is an inflammation of the peritoneum, typically causes what they call ileus. The ileus is a paralysis of the muscular contractions. Retained gas and feces then cause distension, and the stomach empties by emesis or vomiting. So again, if we have peritonitis, it causes the paralysis of the muscle contractions. Remember that in the abdomen, our muscles contract to help push the stool through. So it contracts, pushes the stool until we have to go to the bathroom. Diverticulitis is an inflammation of the diverticulum. So basically what's happening here is inflammation of small pockets at weak areas in the muscle walls. So what will happen is you'll see, as the stool is passing through, you'll have small pockets within the lining, and that's becoming very inflamed. Cholecystitis is an inflammation of the gallbladder. So again, they're not going to call it gallbladderitis, which makes a lot more sense, but cholecystitis is the name for that. So we're looking at inflammation of the gallbladder. Inflammation of the gallbladder can cause significant pain. You'll feel like you have some like acid reflux almost, and just becomes like a burning sensation. That can be inflammation of the gallbladder, and a lot of times you'll get this removed. The gallbladder can have issues when people eat a lot of fatty fatty foods, as well as just more of the fatty foods that are there. So there's two types of nerves that supply the peritoneum. There's the parietal peritoneum, which is supplied, by the same nerves that supply the skin of the abdomen. So perceive pain, touch, pressure, heat, and cold. But then there's visceral peritoneum, which is supply the autonomic nervous system, which produces referred pain. Referred pain is very important to know, where you have something going on in your abdomen, which then refers the pain to one of your shoulders. We'll get to that here in a second, as you can see here. So within the nervous system, you have what they call a synapse point. I wish I had a picture of this. I don't have one showing up here yet. For the synapse, and then it's always like two nerves coming together, and there's a synapse that kind of hooks them in together. With that, these points will cause referred pain. So if we have gallbladder pain, that can refer to the right shoulder, this gallbladder issue, because the pain is then transferred through the autonomic nervous system, okay, through the spinal cord, and says, okay, this is going to hurt here if we have this. Does that make sense for referred pain? All right. So with ulcers, their protective layer of mucus starts to erode, allowing acids to eat into the organs. This may lead to gastric bleeding, and some heal without intervention. So what to know about ulcers and why they're so important. If we have patients that have histories of bleeding ulcers, we can't give them aspirin. Why is that? Why do you guys think that is? Any thoughts? You can put it in the chat box. I just need to see some interaction with you guys. Anybody there?
I'm here.
Okay. So why can't we give aspirin to a patient who has bleeding ulcers? Any thoughts?
Then out their blood even more.
Right. So what is aspirin? What does it do? What is
Thins your blood?
It doesn't thin the blood. It's close though. You're close. So what do platelets do?
They aid in clotting.
Yes.
So the acid would not allow the blood to clot if it was trying to.
Perfect. So remember that platelets help the clotting process, right? So if we give somebody aspirin, another name for it is called a platelet aggregator, which means that the aspirin is making the platelets less sticky to help to prevent further clotting from happening. So if we give somebody 324 milligrams of aspirin who has a current active bleeding ulcer with chest pain, we can actually cause them to bleed more so they can't heal on their own. So that's one of those things where it's contraindicated to give somebody aspirin because of the fact they're having a bleeding ulcer, which is why it's very important when you have a patient with chest pain. Do you have an allergy to aspirin? And then on top of that, you need to make sure that they don't have any bleeding ulcers, active bleeding ulcers. If they don't have anything actively bleeding at this point in time, we can give them aspirin. Ulcers are ulcers, but they're actively bleeding. We need to find that out. Gallstones in the gallbladder, remember, it stores digestive juices and waste from the liver. Gallstones may form and block its outlet. So remember, gallstones can happen, or the gallbladder attack, due to excessive fatty food, which is why you got to live a good diet. I'm not saying ready to diet. I'm not telling people to start dieting. But from your fatty foods to more of your greens and your healthier foods, to kind of have a good intermix between the two. So don't just eat all the fatty foods all day long. You got to have a mix to help clean yourself out. This can cause significant pain and lead to cholecystitis, right? Which is what we don't want, because because what could happen if you have a gallbladder attack and it can't be relieved, they go in there and they take it out and remove it. Pancreatitis is another one, which is inflammation of the pancreas. This is caused by obstructing gallstones, alcohol abuse, or other diseases. Why would it be important to keep your pancreas? What does your pancreas do? Any thoughts? Right? Helps filter, helps clean things. Perfect. So if we have an inflammation of the pancreas, we can cause significant infection with pancreatitis. So signs and symptoms would include pain in the upper left and right quadrants, nausea, vomiting, and abdominal distension. Keep in mind that sepsis or hemorrhage may occur with this, which is why we really need to make sure we're looking for the signs of sepsis, because if we miss it, patients can die from sepsis. Okay, they can go into septic shock, and sometimes it's very hard to reverse that because the patient is so widespread vasodilated from the bacteremia, causing full systemic vasodilation. That blood pressures can drop very low, where they actually need other medications and antibiotics to help clear this out. And I've had a lot of patients that have been so septic that they had to be intubated in the hospital because of how bad the sepsis was. So I just want to keep that kind of stuff in mind. All this stuff leads into something a lot worse if you don't pick it up right away and get them to the ER. Appendicitis is an inflammation or infection of the appendix. You'll have nausea, vomiting, anorexia, fevers, chills, rebound tenderness, and I'll show you guys how to find this here in a second. You could have gastrointestinal hemorrhage and bleeding within the gastrointestinal tract, and it may be acute or chronic. So first of all, where is the appendix located? Where do you guys think it's located? Would it be in the right or left upper quadrant, right or left lower quadrant? Where would it be located? Where would you find the appendix? If you don't feel comfortable talking about it, you can send me a private chat, and I promise I won't relieve your name if you give me a wrong answer.
Lower right.
All right, lower right. That is correct. So the way to locate the appendix, what you're going to do is you're going to locate something called McBurney's point. That's how we're going to find it. So we take and locate the umbilical, and you can do this on yourself if you want to, and then the corner of the pelvis, and you're going to go from the umbilical 3/4 of the way down towards the corner of your pelvis, and you're going to put firm pressure there. That is where your appendix is located. If you have a patient that has appendicitis prior to your appendix actually bursting, okay, once it bursts, then remember all those free fluids go out into the abdominal cavity, causing significant infection and bleeding, right? So if you push on it, push down deep, okay, they're going to have 10 on 10 sharp pain. They're going to want to probably punch you right in the face. That's the kind of pain you're going to have with this. And it's going to hurt more with that rebound tenderness. That's what I was talking about here, the nausea, vomiting, the anorexia, fever, chills, rebound tenderness part. As you palpate and come back up, it's going to hurt extremely bad. These patients need surgical intervention if they truly have appendicitis. And what they're going to do is they're going to check for inflammation, and by doing that, they do blood work. Something called a CRP they'll do. They'll be able to figure that out. Esophagitis would be the lining of the esophagus becomes inflamed by infection or acids from the stomach. So how would your esophagus get acids from the stomach? Vomiting. Right, coming back up. You'll have pain in swallowing, you'll have heartburn, nausea, vomiting, sores in the mouth. Here comes the next one that's listed here, and this is something very dangerous, is esophageal varices, which is the capillary network of the esophagus starts to leak. You'll have fatigue, weight loss, jaundice, anorexia, edema, and abdominal pain. I'm going to go back one. Esophageal varices, if you have a true, and this you'll see this a lot more with alcoholics that can develop the esophageal varices, because you start with the amount of alcohol they're intaking can actually cause weakening in the esophagus, right? So if they have esophageal varices, a history of it, and the varices rupture, they can literally deplete their entire blood loss all over the ground through vomiting. 85 or 90% of the esophageal varice ruptures have been working codes when I get on, by the time I make it to the scene. And when you walk in, it looks like literally somebody was stabbed and they bled all over the place. There is that much blood loss. Very hard to manage an airway with this. In order to get intubations from medics, it's very tough to manage. So if you have a patient that has a history of esophageal varices, all right, and they're starting to cough up a little bit of blood, get them to the ER, because they're going to need to go down with a scope and try to fix it. What we want to do is not have a varices rupture. Mallory-Weiss syndrome is a junction between esophagus and the stomach starts to tear. The principal symptom of this, is vomiting. Gastroenteritis is an infection from the bacterial or viral organisms caused by non-infectious conditions. And the primary symptom of this, or principal symptom, is diarrhea. Gastroenteritis is one of the most typical diagnoses in the emergency department for abdominal pain for people that have diarrhea if they can't find anything else wrong. They'll diagnose you with gastroenteritis and send you home with this. Diverticulitis is when fecal matter becomes caught in the colon walls, causing inflammation and infection. And you'll have fever, malaise, body aches, and chills. People that have diverticulitis as a history will tell you, I have a history of diverticulitis, and it feels like my last diverticulitis attack. They'll let you know. They know it is. All right. However, with diverticulitis, causes significant pain. These people here usually will need some form of controlled substance of a narcotic to help with that. Hemorrhoids caused by swelling and inflammation of the blood vessels surrounding the rectum. You'll have bright red blood during defecation. So when you're going to the bathroom, you'll notice bright red blood. Cystitis, or a bladder infection, is very common. Also called a UTI. So we talked a lot about UTI a little bit earlier, which is caused by a bacterial infection that comes through the urethra up into the bladder, which becomes serious if the infection spreads to the kidneys. That's when we start getting our urosepsis. So what will happen is we'll have reports of urgency and frequency of urination. So you're going to pee a lot. The patients that have UTIs, they're constantly peeing over and over and over again. They'll also have a foul odor to it as well. If you're looking to sniff someone else's urine, you'll have an odor to it. Usually I ask the patient, do you notice any different odors to your urination? All right, so the kidneys play a major role in maintaining homeostasis. By doing so, it eliminates waste from the blood. That's what the job of the kidney actually is. So the waste products, urea, remains in the blood from that. So when the kidney fails, your uremia results, causing the waste product urea, which remains in the blood. Kidney stones can then grow over time, and then they can cause a blockage. Remember, that's calcium buildup within the kidneys, causing kidney stones. And a lot of times, if you can't pee it out on your own, they may have to go in and do surgical intervention. I call it surgical intervention, to have that stone removed. Acute kidney failure is a sudden decrease in kidney function, reversible with prompt diagnosis and treatment. So you got to have, in order to be able to treat kidney failure, you got to have someone that has urology. The hospitals that we have locally that we transport to for your clinical ride time do not have urology. The closest one would be Lakes Region Hospital and or Frisbee. Chronic kidney failure is irreversible at this point. These patients here are going to end up going on hemodialysis. It's progressive, it develops over months and years, and eventually dialysis or transplant is required for this. And dialysis patients spend a lot of time in dialysis center getting dialysized. Usually it's 3 days a week when they go. The female reproductive organs. Gynecologic problems are a very common cause of acute abdominal pain, and the lower quadrant pain may relate to the ovaries, fallopian tubes, or uterus. So you have a female, again, who's sexually active, and you have to ask these questions. Are you sexually active? Now, if you have a 16-year-old female, lower abdominal pain, you need to ask the question, have you been sexually active? Also, have you been using protection while you're sexually active to make sure it's not an STD causing the pain as well? So again, it may be easier to have, if you have a female employee, to talk with another female, but if you're an all-male crew, you have to talk to them. And a lot of times, they won't even discuss it with you, especially if they're in front of their parents. So you may have to separate mom and dad from the child to be able to have this conversation so they can give you the true answers to what's going on. And then you need to get them to the hospital. All right, some other organ systems is the aorta, which lies immediately behind the peritoneum. So weak areas can result in what they call an abdominal aortic aneurysm or a AAA. AAAs are very difficult to detect, and you want to use extreme caution when assessing or detecting a AAA because they can rupture. So think of one way to kind of illustrate what this actually looks like. The aorta, if you were to take a quarter and put that into your body, that's the size of the aorta in diameter. So you can imagine that's your major blood supply through the body. So if that has a tear or has a aneurysm and the aneurysm bursts, patients that have a AAA and they actually burst in the field, usually they live about 90 seconds to a couple minutes and then they're dead. A lot of people that have ruptured AAAs don't even make it on operating tables if they're even cut open. Because remember, your major blood supply with a diameter of a quarter, full leak. Pneumonia can also cause the ileus and abdominal pain as well with that. Hernias can occur with protrusion of an organ or tissue through an opening of the body's cavity where it does not belong. If we have a person that has a hernia, do not take your thumbs and push it back in. They may do that to themselves. They've had it before. They kind of push it back in and they're good to go. We do not relocate hernias. Right? Let the physicians handle that kind of stuff. They may not always produce noticeable masses or lumps, which is why you still need to palpate the abdomen. But if you have a strangulation hernia, that's a serious medical condition because that's when your intestines have come out and they herniated and they've twisted to the point where they're losing blood flow, right? And this can cause significant pain. It can cause tissue death as well. Serious hernia signs and symptoms are a formerly reproducible mass that is no longer reproducible or reducible. Should say reproducible. A formerly reducible mass that is no longer reducible. Pain at the hernia site, tenderness when the hernia is palpated, or there's red or blue skin discoloration. These are patients that have significant or serious hernias. These patients need to get brought to a hospital right away for these. So as part of our assessment goes, we're looking at scene safety. So consider wearing a gown and disposable protective covers for shoes for this, if you have the availability to. Mechanism of injury, nature of illness. may be the result of violence. So it could be something from a sexual type deal, sexual assault, to just violence itself. If they're pale and sweating with a tearing pain, they may have a AAA. These patients need to get to a trauma center that can do surgical intervention right away. Characteristic odor of gastrointestinal bleeding. If you have not had a chance to smell a GI bleed, you'll never forget it once you do. Remember that you can have an upper GI and or a lower GI bleed. So lower GI, obviously through the rectum, upper GI bleed will be through vomiting. If they have abdominal pain, you're doing your assessment. One of the questions you do want to ask, when you had a stool, if you've had any stools at all, did you notice any blood? What color was the stool? Was it very dark, like almost a black in color? Because if it's that, that's more of a lower GI bleed. All right, you got to take note of it. If you can, take a sample of the stool, put it into a collection cup or into a baggie and bring it to the hospital, because they have to do testing on that kind of stuff. All right. So the physicians have always asked in the past, can you get a sample? If you can, get it. If not, don't worry about it. We're going to check airway and breathing. So abdominal pain can cause shallow, inadequate respirations because they're trying not to breathe too heavy to make their abdominal cavity hurt more. Circulation, ask about vomit or blood in the vomit or black tarry stools. And then you want to check pulses in both arms. And we need to make a transport decision. Immediate transport is needed if there are signs and of significant illness. So we see the AAA, we see the hernia, strangulated hernia, or things like that. These patients are critical. We need to get them to an ER. Remember getting your sample history, then asking about nausea, vomiting, changes in bowel habits and urination. So when was your last bowel movement? When you had your last one, was it hard to produce stool? Urination, has it been more frequent urination? Have you had less urination? Has it been a burning sensation? Have you had any different smells? Things like that. Weight loss. Have you had any significant weight loss? Now, they lost 3 pounds in a week and they're exercising. Not a huge deal. But if they've lost 8 to 10 pounds in a week, that's significant weight loss, especially if they're not exercising at all. Flatulence and belching, pain, concurrent chest pain, and any other kind of signs and symptoms that you may find. So when doing your physical examination, a normal abdomen is soft and non-tender or not tender. If you have pain and tenderness signs, this would be a sign of acute abdomen issues. So you want to expose and assess the abdomen and palpate gently. Unless you feel that it's something like with appendicitis, you got to push it a little bit farther to get to the appendix, understandable. When you are palpating, think of the belly button, the umbilical, as the center of the abdomen, and go above and below that, palpating all 4 quadrants. You don't want to palpate the 4 quadrants all at the same time. You want to make sure you palpate each one individually. Do vital sign checks. So check respiratory rate and pulse rate. Obviously, blood. Oh, wrong button. Also checking the blood pressure as well. When you're doing your reassessment, you want to do frequent reassessment is definitely important because abdominal pain can change over time. Also keep in mind that anybody with abdominal pain should be getting a 12-lead EKG. So main EMTs, new protocol rollout comes out very soon. 12 leads are within your scope of practice. All right. EMTs for New Hampshire, already in your scope of practice. Patients that are diabetics can have significant neuropathy, that can have upper gastric pain, abdominal pain, and truly they're having a STEMI, they're having a heart attack. So when you're assessing your patient, get that EKG done. Okay, I'm not, remember, you can't interpret it, but you're getting that initial printout because things can change over time. That's why they're saying frequent reassessment is important. Reassess vitals every 5 minutes for significant abdominal pain. Because if they have a bleeding organ of some sort, or let's say kidney issues where they're actually bleeding out, vital signs can change over 5 minutes quickly and they can go into shock. So you want to assess your interventions. You want to including treatment for shock and emotional support. And then transport the patient in the most comfortable position. So if they feel better laying on their left side, then lay them on their left side. If they feel better with their knees bent, then place a pillow or a blanket underneath their knees and let their knees be bent a little bit to help relieve some of the pressure on their stomach. Some of the newer stretchers actually bend at the knees for you. The older ones, you just got to put some towels or blankets underneath there or a pillow, and then they're good. Remember, you cannot treat the cause of an acute abdomen. You can't treat it. All we can do is bring them to the hospital. Take the steps to provide any kind of comfort and lessen the effects of shock. So treat for shock even when obvious signs are not apparent. So give them oxygen. But also remember, oxygen also helps with anxiety, and it can also help decrease nausea. Now, New Hampshire EMTs, keep this in mind. You're allowed to have the patient sniff an alcohol prep 3 times. By doing so, that can also help reduce nausea if you don't have any ALS coming in behind you. So the sniffing of an alcohol prep is in your scope of practice, in your protocol books for New Hampshire. It says that you can have them sniff an alcohol prep. Don't ask me how it works. I have no idea how that works. I can try to look it up, but I've yet to be able to find too much information on it when I did look it up on how that actually happens. But the sniffing of an alcohol prep can actually reduce nausea. After releasing the patient to the hospital staff, clean the ambulance equipment and then clean your hands as well. Dialysis. So dialysis is definitely an emergency type issue if they're having a problem with that. I'll go that more in detail here in a second. So dialysis is the only definitive treatment for patients in chronic kidney failure, or they call CKD, chronic kidney disease. So dialysis helps filter the blood, cleans it of toxins, and returns it back to the body through a big machine. Right? So if the patient misses dialysis treatment, they can actually start developing pulmonary edema. They can also become very hypotensive if they've had too much taken off. And these patients here, after dialysis, they can't leave right away. They have to monitor vital signs. They also have to wait for their fistulas actually to be blocked, to clot up as well. Some services transport patients to and from dialysis centers. More of your BLS stuff when this happens. Just keep this kind of stuff in mind as you're doing your assessments as well. So with dialysis emergencies, if they have a fistula present, so you're going to find a big lump underneath the skin, usually in the right and or left bicep. If they have one of those placed, okay, that's the access port for them to be able to do the dialysis. Do not place a tourniquet over those. You may have to hold pressure and plug the hole if they're continuously bleeding from them. Do not apply a tourniquet because it can dislodge the tubing that's inside. Also, do not take blood pressures on that arm as well. Not even on the forearm. That arm is off limits, kind of like someone who has breast cancer. Same thing. Some adverse effects of the dialysis can be hypotension, muscle cramps, nausea, vomiting, hemorrhage from the access site, and infection at the access site. So emergency care for the dialysis, ABCs, high flow O2 if indicated, manage any bleeding from the access site. Again, no tourniquets for them. You just go to apply pressure. Position in a sitting up position in case of pulmonary edema. Supine if the patient is in shock and get these patients to a hospital. A lot of times 911 may be called for a patient who just got home from dialysis. And one of the biggest things out there now you're seeing with dialysis is home dialysis. So they bring machines to their homes and do dialysis at home. If they've had too much taken off, that can actually cause patients to have more hypotension. So again, not that you're going to be giving any fluids at the EMT level, but we have to watch how much fluid actually goes in through IV therapy. All right, so let's do a quick review. The blank lies in the retroperitoneal space. Is A, B, C, or D? Remember, you can always send me a private chat, but I want to hear from all you guys on this.
Pancreas.
All right. So the answer is B. The pancreas, the kidneys, and the ovaries lie in the retroperitoneal space behind the peritoneum. Perfect. Number 2. Which of the following is not a solid organ? So not a solid organ.
D.
I'm seeing B's and D's come up. The answer is D, the gallbladder. The gallbladder is a hollow organ that concentrates and stores bile, which is produced by the liver. So number 3, we have a 34-year-old woman. Oh, the answer is A. Let's go through it anyways. A 34-year-old woman with a recent history of pelvic inflammatory disease presents with acute severe abdominal pain. Her abdomen is distended and diffusely tender to palpation. Based on your findings thus far, you should suspect, everybody should be saying A because I showed you the answer already, but it's peritonitis. So it'd be an inflammation of the peritoneum. Number 4, so most patients with an acute abdomen present with
D.
seeing B's. I think I'm seeing some D's online. Some B's. The answer would be D, tachycardia. So commonly seen in patients with acute abdomen is usually a result of severe pain. Hypotension is not seen in all patients with abdominal pain. So anytime a patient has a pain response, a lot of times you'll see that tachycardia. Something to keep in mind though when you deal with the elderly in abdominal pain, a lot of times we're on beta blockers. Remember that beta blockers slow the heart rate down. So you got to just kind of keep that in the back of your head. So when you're doing your sample history, it really is important to look at that medical history, the medications list. Because a patient that should be tachycardia, should be tachy, may actually be normal or Brady because they're being medicated. So that could actually mask shock or shock-like symptoms. Okay, so kind of keep that kind of stuff in mind. Number 5. So which of the following signs or symptoms would you at least likely to find in a patient with an acute abdomen? All right, seeing a lot of B's. The answer is B, soft, non-tender. That's normal. A condition in which a person experiences the loss of appetite is called what? All right, a lot of D's, so anorexia. Number 7, the medical term for inflammation of the urinary bladder is what? Perfect. Cystitis. Number 8, if a hernia is incarcerated and the contents are so greatly compressed that circulation is compromised, the hernia is said to be what? Perfect. C. Good job. Number 9. So a 70-year-old man presents with an acute onset of severe tearing abdominal pain that radiates to his back. His blood pressure is 88/66, pulse rate of 120, respiratory rate of 26. The treatment for this patient should be what? So all you guys should be thinking when you're hearing this is a AAA. The tearing and back pain with hypotension and tachycardia. A. Severe tearing. Rapid transport. And number 10, in which position do most patients with acute abdomen pain prefer to be transported in? Yeah, on their side in a fetal, almost like a fetal position. All right. Any questions on that chapter at all? You guys have any questions? Are you good? Good.
I'm good.
Love it. All right, let's take 10 minutes. We'll come back at like 7:25. Then we'll do the next chapter. All right, so let's talk about chapter 22, psychiatric emergencies. So I think out of what we deal with between chest pain, abdominal pain, shortness of breath, is a lot would be, check the PD for evaluation. A lot of times you go for psychiatric. We're coming into that season now where we start seeing significant depression. We're getting into the colder months. The snow will be starting here at some point in time. Loved ones that have been lost and they don't want to celebrate the holidays. Getting into January when all the festivities are done, going into kind of like the gloomy 4 months where we start seeing spring and things start becoming a little bit better. So we're going into the season where we start seeing more suicidal attempts or suicide ideations, to significant depression and things like that. So we just got to pay attention with these patients. And a lot of these patients need what they call PFA, which is psychological first aid as well. Just someone to talk to. So let's get into obviously the same thing, treating for the acutely ill. And then how to recognize a psychiatric type of emergency. So behaviors that pose a risk to the EMT patient or others. Basic principles of the mental health system. The assessment and management of acute psychosis, suicidal and risk, and agitated delirium. So EMTs often care for patients experienced in a behavioral crisis or some type of psychiatric emergency. We get called for the evaluation. The crises may be a result of acute medical situations, to mental illnesses, to mind-altering substances, stress, and many other causes that are out there. And I know that in our last practical session, we actually talked a little bit about this as well, just on the psychiatric stuff and excited delirium and medications and things like that, which we did discuss. So there's myth and reality. So at some point, most people experience an emotional crisis. This does not mean that everyone develops mental illnesses. This means that they had an emotional crisis at some point. Then we move forward and go from there. So don't jump to conclusions concerning yourself or your patient. Somebody just might be having a bad day. They may have just lost a loved one that puts them into this emotional crisis that they're having versus a true mental illness. So the most common misconception is that if you are feeling bad or depressed, you must be sick. That's not necessarily the case. Again, there are many justifiable reasons for feeling depressed. I mentioned like a death of a relative or a friend, divorce, things like that you have to pay attention to. Many people believe that all individuals with mental health disorders are dangerous, violent, or unmanageable. There's only a small percent that fall into this category. A lot of these people are just they have the mental health disorders. They're not dangerous people. They go into these slumps where they become very depressed, or their medications could be off and just need some readjusting. And they're not harmful. They're not harmful to anybody. They're just down in the dumps and need to just talk with people. EMTs may be exposed to a higher proportion of violent patients, but as a whole, the numbers are still very low. We just get called for a lot of the violent ones. Many people believe that all individuals with mental health disorders are dangerous, violent, or manageable, but keep this in mind that communication is key for this. Patients may de-escalate when a level of trust is established. And you may also be able to predict any kind of violence that are there looking at different body language. So again, if communication is key, we got to talk with these patients. Don't look down to them, okay? Look right at them when you're having a conversation. Don't make it so they feel threatened to be around you. Just kind of be there for them, have a conversation, try to talk them down. A lot of times it's very easily to de-escalate that once, like I said, once the level of trust has been established. Behavior is what you can see of a person's response to the environment and his or her actions. So most of the time, people respond to the environment in reasonable ways. So over time, people learn to adapt to stress, and sometimes stress is so great that the normal ways of coping do not work. All right, so hopefully they're reaching out to talk with somebody to kind of help them get through their bad times that they're having. And sometimes they'll end up calling PD, or like a crisis hotline. But if they're making threats to hurt themselves, they're going to notify law enforcement to come over to make sure you're okay, or things like that. Keep in mind that once you become a medical provider holding a license, you are mandated reporters as well. So if you have patients that are threatening to hurt themselves, or somebody calls you, even a friend, and they say, I'm going to kill myself tonight, you need to report that you're a mandated reporter by the state holding an EMS license. So you got to keep that kind of stuff in mind when you see certain things. And really, we're only doing it for the benefit of the patients, right? We're trying to be there to help them out, make sure they don't do something for a lifetime of regret. Reactions to stress that are acute and those that develop over time can create a crisis. So a behavioral crisis or psychiatric emergency includes patients who exhibit agitated, violent, or uncooperative behavior, or who are a danger to themselves or others. This is when we get called in, when behaviors have become unacceptable to the patient, family, or community. People live every day with depression. It's when they start becoming uncooperative, violent, or agitated, where we have to come in and kind of de-escalate that situation in hopes that they'll calm down, come to the hospital, get evaluated by a mental health expert, and then get released or go to a place that can help you with further care with that. Don't be judgmental also when you're doing your assessment. A patient may also have dementia or depression, behaviors that interfere with activities of daily living. So chronic depression is persistent feeling of sadness and despair, or maybe a symptom of a mental health disorder. So to find out if patients have depression, either ask them, do you have a history of depression or anxiety? Or look at their medications and see what medications are on and see if that can kind of lead you towards the fact that maybe they have chronic depression as well. If an abnormal or disturbing pattern of behavior lasts for a month or more, this is now a matter of concern. So when a psychiatric emergency arises, the patient may show agitation or violence, or may become a threat to self or others. At this point in time, these patients need to be evaluated. Whether they go by law enforcement or they go by ambulance, it's going to be up to the patient whether they're going to cooperate or not for you. But once they've made threats themselves, they need to go for an evaluation by a physician. And to kind of go over what happens with this. So if you have a patient who is having a psychiatric type of emergency. And we transport them to the hospital. They can be in Maine, blue papered. In New Hampshire, it's what they call an IEA. In Massachusetts, they call it a Section 12. So, I mean, it's all still kind of the same stuff. Patients get blue papered or IEA, depending on what state we're talking about, for Maine or New Hampshire. And these patients then are forced to be evaluated. So when they're in the ER, they're in a mental health section or a room, a locked room or unlocked room, depending on whether or not they're a threat or a flight risk, or IEA'd. And they get evaluated by a physician. So prior to the physician being evaluating them, they have to get a blood draw and a urine test, make sure there's no toxins in the system, and make sure they don't have like a UTI and things like that as well, that could be causing them to have an altered behavior. Once all that's said and done and lab work comes back and the physician comes in, they can determine whether or not, yes, they need to be seen by mental health, or no, everything's good, they can just go home. If they decide that mental health evaluation is needed, what they utilize around here is Northern Human Services. They're contacted, they do a video conference with the patient, they have discussions, and they say, this patient really needs to go to a psychiatric facility, or they're just having a bad day, and they should be good to go home. So that's kind of how the process goes. And the thing is that there's such a short number in beds for psychiatric facilities. There are sometimes these patients are waiting in an ER room or upstairs on like a medical surgical unit with door watches for 10 to 14 days or even 20 days long, because there's no beds available for them to go get the help that they actually need. So mental health disorders are common throughout the United States, affecting tens of millions of people each year. A psychiatric disorder is an illness with a psychological or behavioral symptom that may result in impaired functioning. Anxiety disorder is among the most common, and we deal with people with anxiety all the time. So with anxiety disorders, they include generalized anxiety disorder, panic disorders, social and or other phobias, post-traumatic stress disorder, or obsessive compulsive disorder like OCD. The U.S. mental health system provides many levels of assistance. Professional counselors are available. For marital conflict or parenting issues, more serious issues are often handled by a psychologist, and severe psychological conditions require a psychiatrist. Most psychological disorders can be handled through outpatient visits. However, some require hospitalization in specialized psychiatric units. These are patients that are either sometimes are IEA'd or blue papered, and they need to go to another facility where they can be watched because they are a threat to themselves or a threat to others. So psychiatric disorders may have underlying causes. So social and situational stress, such as divorce or death of a loved one, can definitely cause some situational stress, which can put someone over the edge. Diseases such as schizophrenia. So schizophrenia is very dangerous because there's a lot of voices going on in someone's head, and they really can't get at their thoughts. If normally for my EMT classes, if we're doing in-person stuff, which I can do on one of the practical days that we're doing for this, and you can do it from home too. If you just type in schizophrenia on YouTube, all right, what can happen, what it'll bring up is one of the videos. What you do is you close your eyes and you try doing a laundry list of something. Write down 10 items you want to buy at the grocery store, okay? But close your eyes and just listen and try to focus, or not write down, but think of 10 things. I should say write them down because you can't see. Think of 10 things you would want to buy at a grocery store while listening to different voices in your head tell you that you're a loser, that you're a horrible person, and just going back and forth and back and forth and back and forth. So it's one way to make you feel what they feel when you're dealing with someone with severe schizophrenia. Physical illness, such as a diabetic emergency, chemical problems, such as alcohol or drug use, biological disturbance, such as electrolyte imbalances. All these things can be underlying causes of a psychiatric disorder, where all they need is medications to help fix that and or become sober and getting off the drug or alcohol type of use that's there for the chemical problems. And it just so happens that where you guys are doing ride time, you actually covered 2 different places that deal with these types of disorders as far as alcohol or drug as well, different treatment centers. So some pathophysiology behind this is an EMT is not responsible for diagnosing an underlying cause of behavioral crisis or psychiatric emergency. You should understand the 2 basic categories of diagnosis a physician will use: organic or functional. Organic disorders are brain syndromes, organic brain syndrome, which is a temporary or permanent dysfunction of the brain that is caused by a disturbance in a physical or psychologic functioning of the brain tissue. Causes include sudden illness, traumatic brain injury, seizure disorder, drug and alcohol abuse, overdose or withdrawal, and diseases of the brain. Altered mental status can arise from hypoglycemia, hypoxia, impaired cerebral blood flow, or hyperthermia or hypothermia, which is why when we have these patients, we need to do different tests if they'll allow us to do so, as long as we are being safe. So if you need to check a blood sugar on someone who's altered and they're fighting with you, taking out stuff to check a blood sugar may not be the best option at that point in time. All right. So we got to play it by ear, make sure that we are safe first. Our safety always comes first. Right, and then our crew, then our patient. Functional disorders is a psychological disorder that impairs bodily functions when the body seems to be structurally normal. And this would include anxiety, depression, or schizophrenia. The chemical or physical basis of these disorders does not alter the appearance of the patient itself. So again, these are things that are going on inside their head that are causing them to feel this way. I'm very anxious as well. New Hampshire has a phenomenal anxiety protocol now. It's med control order for paramedics, but still, they have the ability to give patients Ativan or things like that to have a sedative to kind of control them without knocking them completely unconscious. But as a regular EMT, all regular EMT skills are used in a behavioral crisis. Other management techniques are also involved with this because we need to get down to the same level as them, as you can see here. Don't tower over somebody. Provide a safe approach. Get down to the same level as them. Just don't get below them. Always make sure that your back is always towards an exit where you can turn and run away if needed. Never put yourself in a corner where someone can harm you and trap you. All right? And just have a conversation. Sometimes people that have behavioral issues just need somebody to listen to. So as we approach, we want to make sure we assess the scene for scene safety. Again, make sure you always have an exit route before you go in and talk with somebody. Ensure you can communicate with them. Know where all the exits are. Don personal PPE. Have a definite plan for action. Okay, so make sure you know what you're going to be going in to do. Urgently de-escalate the patient's level of agitation and calmly identify yourself. My name is Kevin. I'm one of the paramedics. I'm here to talk with you. This is why we're here. What's going on today? And ask them, what's going on? What's been bothering you? Let them have a chance to speak, but don't allow yourself to get manipulated. All right? Don't let them get the upper hand. Try to keep things on the even playing ground. If not, make sure you're one step ahead. All right? Be prepared. And don't lie to people, because sometimes they can read right through you, and you're not going to gain that trust that you need to be able to perform the right interventions. Be direct. Be prepared to spend extra time. You might be with these patients for a while. Do not get too close. Avoid fighting with the patient. Be honest and reassuring. And don't judge anybody. When you start doing this kind of stuff, okay, you start fighting with the patient. I'm not saying physical fight, arguments. You're telling them lies. You're not being reassuring with them. You're judging them. All you're going to do is piss them off. You're not going to be able to get where you need to get with them, and it could cause them to become more agitated to the point where they're actually going to harm you. All right, so you want to make sure we avoid that by de-escalating it by being all of these here. So remember the scene safety, very important, right? If the situation is potentially dangerous for you and your partner, one of the questions you should be asking, if it's dangerous, then don't go in. Let PD clear the scene first. Make sure that there's no guns, weapons, or any kind of sort that's going to harm you, right? Have them clear the scene. Remember, we don't have the power to arrest. We don't carry weapons like guns, tasers, things like that. At least we shouldn't be carrying those as EMS. But you never know. They have the power to arrest. We don't. You should stage until law enforcement personnel have secured the scene. Or should you stage? Do you need immediate law enforcement backup? A lot of times when you're being dispatched to a call, you know, if you've been there multiple times, you may know that law enforcement is needed. So you can say, hey, have law enforcement please start this way prior to you getting there, because you know it's a repeat person that you go to all the time. Just because you've been there 30 times in the last month does not mean that time number 31 they're not going to turn against you. I hear that all the time. Oh, we're familiar with the patient. You can cancel PD. No, don't cancel law enforcement. Because at one time you go, they could be in a whole different state of mind and they could actually harm you when you walk through that door. You have no idea what they are going through. Does the patient's behavior seem typical or normal for the circumstances there? And are there any legal issues involved? These are things you should be looking at for your scene safety. Does the patient's behavior seem typical or normal for the circumstance? And are the legal issues involved a crime scene? Do you have consent? Is it a refusal? Then we'll take standard precautions and request additional resources early. Get people started with whatever you need. Looking at the mechanism of injury or nature of illness, we're going to determine the mechanism of injury or nature of illness. We're going to note any medications or substances that may contribute to the complaint or be treatment of the relevant medical condition. So as you're looking around, look at the floor, the tables, things like that, and see if there's any pills laying around. All right. Now, if they're unconscious, we got to find out what they took. So we can look at different toxidromes we talked about in toxicology to kind of determine which route they may have gone down. But having a pill identifier or just using Google search and typing in what you see on the pill can give you loads of information. Right? If you have just pills laying around and no bottles, right, you have no idea what they may have taken. So sometimes it's not a bad idea to look them up or have your partner or somebody else, like or whoever you have there, take out their phone, start typing in the medications that you see, whether it's oval or round, are different scores in it versus numbers and letters. A lot of times that'll help you determine what's really going on with the patient. Form a general impression. So begin your assessment by the doorway or from a distance. Perform a rapid physical exam and observe the AVPU scale. And establish a report with the patient. Talk with them. Get down to the level. Don't stand above them. Don't tower over them. Don't put them in a position where they feel like they're being threatened. And you should also not be threatened yourself. Just go in there and have a conversation. Airway and breathing. So obviously ABCs, check airway and breathing. Evaluate your patient's breathing. Pulse ox if available. And they allow you to put it on their finger. They may tell you no. If they're talking to you in full sentences and they're making sense and their skin is pink, warm, and dry, I'm not overly concerned about a pulse oximetry at this point. Now, if they were cyanotic and they were lethargic, that's a whole different story. But again, if they're not, they're talking oriented, and they're just agitated that you're there, a pulse oximetry is not going to make a difference in your treatment. At least not yet. Assess for pulse rate, quality, and rhythm. Evaluate for the presence of shock and bleeding, and evaluate skin color and temp and cap refill. Then we're going to make a transport decision. So unless the patient is unstable from a medical problem or trauma, prepare to spend some time with the patient. This may take time to gain the patient's trust, but we need to make sure we gain trust to get them to go to the hospital. We're going to investigate the chief complaint and obtain a sample history. So consider 3 major areas of contributors. 1, is the patient's central nervous system functioning properly? 2, are hallucinogens or other drugs or alcohol a factor? And 3, are significant life changes, symptoms, or illnesses involved? So we have to ask these questions in specific to the sample history, but the events leading to illness or injury, we got to ask these other questions in our heads and to the patient. Are you taking any medications? Because, well, I'm not taking anything. And you obviously know that they are by the way they're acting. And just let them know. We give medications as well in the ambulance to help you, and what you have taken may react to what we're going to be giving you, therefore in turn could kill you. We need to know what you've taken for medications or any kind of recreational drug. And usually by the time they tell them they're going to die, because usually you're not there for a suicidal issue, it could just be the fact that they're, well, maybe it could be, either way. A lot of times they're doing that more for attention than they are actually wanting to die, and they'll give you the information you're looking for. But if not, you got to look at toxidromes and try to figure out where this patient is going with this and what they've taken. And poison control will be your friend for this kind of stuff, especially when they've overdosed. They're going to tell you exactly how to treat your patients. As also part of the sample history as well, you may be able to elicit information not available to the hospital staff. In geriatric patients, consider Alzheimer's disease or dementia. And in your assessment, remember you have 2 primary goals: recognizing life threats and reducing stress of the situation. And you need to use reflective listening. Listen to these patients that are talking to you. They have something to say. It makes them feel important as you're assessing them. A lot of times, if you just listen, they'll probably do more for you when you're asking them for any kind of history taking. So these are different questions to ask. Does the patient appropriately answer questions? Does the patient's behavior seem appropriate? Does the patient seem to understand you? Is the patient withdrawn or detached? Are they hostile, friendly, happy, or depressed? Are the patient's vocabulary and expressions what you expect under the circumstances that are currently there? Interesting story to bring behind this. I had a patient years ago where I had an 8-year-old that had a broken femur. 8-year-old, a broken femur. It happened inside a house. Right, the femur was so mid-shaftly broken that his leg was actually in a bent position and we couldn't straighten it, but that was the most position of comfort. Now, if my child broke their femur, I would be obviously really concerned. I think any one of you guys would be as well, right? However, the parents were on their cell phones talking about their day. The other parent had no concern, was playing on their computer, and this poor child, 9-year-old, has a broken femur. Well, the femurs just don't break. And they said that a dog, when he was sitting cross-legged, and a dog jumped in his lap and broke his femur. I didn't buy it. Took the kid to Maine Med. They took care of him, but something seemed suspicious. So again, expressions to what you expect under the circumstances, that didn't make sense to me. I don't know what you guys feel with my story that I just told you, but to me it didn't make any sense. Again, if it was my kid, I would be all about trying to find out what happened and what's going on, and I'd be wanting to go with the kid to the hospital, things like that. The parents wanted nothing to do with it. Is the patient's memory intact? Check orientation to person, place, time, and events. So what day, month, year, who am I? Does the patient express disordered thoughts, delusions, or hallucinations? Do things not make any sense? One second. All right. So in the physical examination, if it's an unconscious patient, begin with a physical exam, head to toe, and don't forget to check the pupils. Very important. In a conscious patient, they may not respond to your questions because they don't want to talk with you as well. I've had a couple patients recently that have been catatonic. Talk about interesting when they are completely stable, but they're just gone out there. So we've had some catatonic patients as well. Those are interesting to deal with. You can tell a lot by the patient's emotional state from facial expressions, pulse rate, respiration. So if their heart rate's up, respiratory rate's going up a little bit, their facial expressions are getting, they're look like they're pissed off. It's probably because they're agitated. Back off a little bit. Look at the patient's eyes. If a blank gaze or rapidly moving eyes could mean central nervous system dysfunction. All right. So rapidly moving eyes could be what? They could be taking other medications, right? Patients who are on methamphetamines, they're all over the place. They bounce around like crazy. So this is something to think about. So again, take a look at what you have, look at your toxidromes, and see what you potentially could have taken. Then make a transport decision. Have law enforcement or firefighters accompany you if possible. So in New Hampshire, as far as the protocols go, if law enforcement handcuffs a patient, that law enforcement officer has to be in the back of the ambulance, not tailing behind you in their cruiser. They have to be in the back of the ambulance. All right, that is New Hampshire protocol. Transport by ground. All right. Make the patient comfortable, Fowler's and or high Fowler's position, whatever makes them comfortable. And also, is there a specific facility to which the patient's psychiatric emergencies are transported to? We do not take patients to psych hospitals. Okay, it's in a 911 setting. We cannot do that. They have to be evaluated and accepted. Every hospital around can take psych patients that I know about. I don't know of any that do not take psychs. They go in, they get evaluated, then they get transferred to a psychiatric facility. So, and they have teleconference resources that they utilize. Never let your guard down on the reassessment. Many patients will act spontaneously. If restraints are necessary, if you're using physical restraints, reassess and document every 5 minutes respirations, pulse, motor, and sensory functions in all restrained extremities. Right? Back to never let your guard down. Never let it down. Always be on alert and look for signs of changing in agitation. As far as interventions go, there is often little you can do during the short time you'll be treating your patient. So diffuse and control the situation. Talk with them, have a conversation. Safely transport the patient to the hospital. And if you think pharmacologic restraint is necessary, call for ALS. Paramedics carry ketamine, and we also carry benzodiazepines to help sedate the patient. We also carry Haldol as well. So we have a lot of stuff that we can utilize to take a patient down using pharmacological restraints. But I'd rather see somebody be in normal restraints than actually taking somebody down and having to maintain their airway because we've sedated them. Communication and documentation. Give the receiving hospital advance warning or psychiatric emergency. A lot of times they have to have security meet them downstairs. So give them enough heads up. Document thoroughly and carefully. Remember, you may be the only documentation about the patient's distress. And if restraints are used, you have to say what types and why they were put on the patient. We can't just restrain anybody. We have to do it if they're a threat to others and ourselves, and themselves. Sorry. So that's the time we would actually utilize restraints. Psychosis is a state of delusion in which the person is out of touch with reality. So we have acute psychosis. Causes would be intense stress, schizophrenia, delusional disorders, and are mind-altering substances that are out there. Schizophrenia is a complex disorder that is not easily defined or treated. So typically onset occurs during adulthood, and influences thought to contribute include brain damage, genetics, and psychological and social influences. Remember, schizophrenia is very dangerous because it's got, remember, there's things in there that tell you that you're hearing stuff in your head. They're saying that you're useless, you can't do anything. Go hit that person, attack them, don't attack them. It goes back and forth about how bad you are, about how good you are, but you're a horrible person, and it doesn't stop. Your brain doesn't rest, right? And this can drive someone completely batty to the point where they might do something dangerous to hurt themselves or the people that get the voices to stop. So keep that kind of stuff in mind. So delusions, hallucinations, erratic speech, and lack of interest and pleasure. These are patients that would show signs and symptoms of schizophrenia. Guidelines for dealing with a psychiatric or psychotic patient. Determine if the situation is dangerous. If it's dangerous for you to go in, law enforcement. Clearly identify yourself. Hey, my name is Kevin. I'm here with the ambulance. I never give out my last name. I don't do it. Right? First name only. That's it. Be calm, be direct and straightforward with your patients. Don't beat around the bush, be direct to them. Maintain emotional distances as well. Don't argue with them. Again, don't instigate them. Explain what you would like to do. Involve people from whom the patient trusts, such as family or friends, to gain the patient's cooperation. If I'm getting nowhere with somebody, a lot of times I'll just say, you know something? I'm going to step away. I'll have family come in. Maybe they can convince them. Now, if family is the problem, you don't want family going into the room, right? Avoid that from happening. Trying to separate the problem. But if family is not a problem, absolutely have them come in. Excited delirium. So delirium is a condition of impairment in the cognitive function that can present with disorientation, hallucinations, or delusions. Agitation is characterized by restless and irregular physical activity. So patients may strike out irrationally. I gotta reply back to a message. Hold on a second. Maybe if it works. There we go. All right. I think it's made unfroze. We're good now. It's working. All right. So some signs or symptoms of delirium would be hyperactive irrational behavior, vivid hallucinations. I'll tell you one in a second. Interesting stuff. Hypertension, tachycardia, diaphoresis, and dilated pupils. So, and this is kind of like what happened with this guy here, is you kind of have an idea of what happened with the excited and the vivid hallucinations that were there. So I was working down in Wakefield, Mass, and I got dispatched to a reported multiple stabbings. They said at least 6 patients. So I'm responding with the Wakefield ambulance with action. And as I'm responding, dispatch got back on the radio and told me they're sending 4 additional ambulances to advise when I get there and start triage. So I get there and I go to the door. PD is not even on scene yet because we're called for stabbings. They said that there was no other issues going on. So we get there, knock on the door. This kid opens up the door and goes, "What are you guys doing? Hurry up and get in here. Get in here quickly. There's blood everywhere. There's bodies all over my house." I'm like, huh, interesting. So I walk into the room and there's nobody there. nothing at all. This kid had no weapons on him. Didn't look like he had any weapons on him. Very clean house. And I'm like, so where do you see the bodies? He goes, well, it's on the couch. Are you gonna go help him or what? I'm like, that's a cushion. There's nobody here. There's no blood. Nothing's going on. So he's like, come here, I want to show you something. I'm like, all right. So we go into the bedroom where he sits down. He's drawing pictures on the wall of his bedroom, and he is sniffing incense. So this guy had some pretty vivid hallucinations. I mean, he thought people were being stabbed in his house, and he was all creeped out by it. All right. His pupils are very dilated. He was sweating all over. So we ended up turning him over to PD. PD ended up taking him in through a section, and he ended up getting evaluated. But again, excited delirium. That stuff's pretty dangerous, and people actually believe this stuff's actually happening. All right, so be calm, supportive, and empathetic. Limit physical contact with these. Approach the patient slowly and respect the patient's personal space. And do not leave the patient unattended because you don't know what's going to happen next. At least if we see them, we know we can try to make assumptions of what's going to happen. So try to indirectly determine the patient's orientation, memory, concentration, and judgment. So pay attention to the patient's ability to communicate, their appearance, the dress, and the personal hygiene. Just look at them and see what's going on with them by making some. And I don't want to say the word judging them, but you want to kind of see how they're presenting to you, how they're dressed, how they look, and things like that to kind of see which way they're going to potentially go with that. If the patient has overdosed, take all medication bottles or legal substances to the medical facility. They have to be able to find out what the medications they OD'd on. Transport the patient to a hospital with psychiatric facilities and refrain from using lights and sirens as it can agitate the patient. If the patient's agitation continues, you want to request ALS assistance, so chemical restraint can be considered. So uncontrolled or poorly controlled patient agitation can lead to the patient's sudden death. So patients with excited delirium, sometimes sedating them to the point where they're unconscious is actually what needs to happen to help keep them alive. Okay, so ALS assistance with chemical restraint should be considered. One of the biggest things we use for that would be ketamine. Works really well for this. With restraint, every pre-hospital care provider, transport provider should create and follow a pre-hospital patient restraint protocol. So know your protocols within the state that you're going to work, because they vary throughout the country and what you can and can't do. The restraint chosen should be the least restrictive that ensures the safety of the patients and the providers. 20 years ago, we could make a backboard sandwich out of a patient, and we can't. That's not allowed anymore. Because it was actually causing more harm than good. Remember that positional asphyxia can actually kill patients depending on how you place them on the stretcher. Okay, especially if you have someone who's very large, laying them onto their back, where the weight of their chest can actually cause them to stop breathing, or if they're laying on their stomach. So you got to consider the patient. Personnel must be properly trained for this kind of stuff. So we have to go through restraint training. If you restrain a patient or person without authority in a non-emergency situation, you expose yourself to a possible lawsuit. So legal actions obviously can involve charges of assault and battery, false imprisonment, and violation of civil rights. So again, follow your protocols. You may use restraints only to protect yourself from others from bodily harm, all right, and to prevent the patient from injuring himself or herself. So if you look at the patient that's here, okay, when you're restraining a patient, You want to have one hand above restrained back to the headrest and the other one down low. You don't want them both up high or both down low because it allows the patient to get different movements. Up high can actually cause more chance for shoulder dislocation, things like that. So again, one high, one low, and then you restrain the legs. You're going to need a lot of manpower for this as well to kind of assist. You may only use reasonable force as necessary to control the patient, which means you cannot hit them, you cannot throw them, you cannot break their bones. Reasonable force. All right. Follow local protocols in your company's pre-hospital policy and consult medical control if needed. Law enforcement really should be involved with patients in a severe behavioral crisis or psychiatric emergency. Right. For one, they're another set of hands, and two, they can also help testify in the courts that you did everything you possibly could to not provide harm to that patient, perform harm to the patient. Before considering physical restraint, use verbal de-escalation techniques. So you want to ask the family to assist you in the calming of the patient, be honest and straightforward, and talk in a friendly tone. Don't go in there agitated with them because they're going to make them more agitated at you, and then it could potentially lead to more physical harm. With this, in the process of restraining the patient, carry the decision out quickly, and how we're going to do this. Okay, so if you're going to restrain somebody, make sure that you guys are all grabbing a body part appropriately, whether it be arms or legs, and make sure everybody has a plan on what's going to happen. The last thing you want is to take somebody down and everybody's going for the same arm. It doesn't really work too well. You should have at least 5 people to help, one for each extremity and one for the head. And there should be a team leader and a plan of action. Remember, use as minimum force as necessary. However, the level of force does vary depending on these factors. The degree of force that is necessary to keep the patient from injuring themselves or others, the patient's sex, size, strength, and mental status, and the type of abnormal behavior. So you really have to pay attention to what the patient is presenting to you. You really want to talk to the patient also throughout the process. Let them know what you're doing, what's going on. You want to treat the patient with dignity and respect, and if possible, show the provider of the same gender should attend to the patient. So you have a female out back. In all reality, if you have a female provider, put them out back with them, and wear the appropriate barrier protection, because psych patients like to bite, spit, throw things at you, and things like that. So you just want to protect yourself. So avoid direct eye contact and respect the personal space that's there. Never leave a restrained person unattended, and you should 4-point both arms and both legs anytime you use a soft restraint. Again, if handcuffs are utilized, remember that if they are, you have to right. Let's see. So monitor the patient for vomiting, airway obstruction, respiratory status, circulatory status, blood pressures, and change in level of consciousness. If you have a patient restrained, remember, they can't protect their own airway. They can't turn to the side, right? So you may have to sit them up, and you may have to actually suction for these patients if they start vomiting. Again, if this were to happen and the patient was actually handcuffed to your stretcher, keep in mind that if law enforcement isn't with you, which is why they have to be, you may be too late. The patient may have already had aspirated at that point. So, and they have to uncuff the patient. So it's easier to use soft restraints versus going with handcuffs. So as far as potentially violent patients go, I mean, violent patients only make up a small percentage of patients undergoing a behavioral or psychiatric crisis. I've had about 90% of the psychiatric patients that I deal with, and I've dealt with quite a few over my time, have been non-violent people. Usually they just don't want to go to the hospital. You tell them the consequences behind not going. Usually they'll say, I'd rather go with you in the ambulance than go with law enforcement. So the potential for violence is always a critical consideration for the EMT, but it doesn't always happen. Usually we get the more simple psychiatric, suicidal, ideation people, patients that just need to have an evaluation done. So it's not too often that we end up dealing with a violent patient. But don't forget, it does happen. And a lot of times, the ones that I've dealt with that are violent are usually the intoxications or the patients that have actually overdosed, things like that. As far as history goes, so over the patient, has the patient previously exhibited hostile, overly aggressive, or violent behavior? And look at their posture. How is the patient standing? Is the patient tense, rigid, or sitting on the edge of his or her seat? If they seem like they're jumpy, if they're in a position where their fists are clenched, step back, exit the room, call for law enforcement if you feel threatened. Don't try to take on a psych patient head on if they become violent, right? Back away, keep yourself safe. If the patient holding or near potentially lethal objects, doesn't have to be a gun or a knife, it can be anything they can throw at you and hit you with. And then how is their vocal activity? What kind of speech is the patient using? Is it loud, obscene, erratic? Is there any bizarre speech patterns which usually indicate emotional distress? So some things to think about when you're assessing your patient is how they are speaking to you. And we really want to try to de-escalate the situation before it's going to physical harm or physical activity. If there is physical activity, however, the most telling factor of all, a patient requiring careful watching is one who has tense muscles, clenched fists, or glaring eyes. If they're pacing back and forth, they're unpredictable. They can't sit still. They're fiercely protecting personal space, right? Try to keep people's space personal, 6 feet or more, right? Don't try getting into their bubble because it just pisses them off at that point, and all they want to do is try to find more ways to cause violence. Some other factors, obviously, are poor impulse control, a history of truancy, fighting, or uncontrollable temper, history of substance abuse, depression, or functional disorders. All right, so suicide. This is something that we deal a lot with, or more of the suicidal ideation, not actually the suicide itself. So depression is the single most significant factor that contributes to suicide. And like I mentioned before at the beginning, we're getting into that season again. We're going to start seeing suicide ideations become a little more amped up during this time of year. It is a common misconception that people who threaten suicide never commit it. Suicide is a cry for help. People need help. Someone in a crisis that he or she cannot handle alone, and this is where immediate intervention is necessary. One of the things that blows my mind is people that have suicidal ideations get taken to the hospital, and because of the lack of resources, they're sent home when they really need someone to watch them because they're at that point, right? So that's something that really bothers me, especially nowadays where there's such a need for psychiatric help out there that people are not getting the treatment they actually do need. So be alert for the warning signs. Air for fearfulness, sadness, deep despair, or hopelessness. Avoiding eye contact, speaking slowly, and projecting a sense of vacancy. Unable to talk about the future. Suggestion of suicide and having any plans related to death. So they say that they want to kill themselves, okay? So let's say I said, I want to kill myself, right? Why did I say that? What's been going on with me to make me want to say that? Then the next question you should ask is, well, do you have a plan? Was there a plan laid out for it to happen? Or are you just reaching out and saying this stuff because you want help, and that's the only way that you can find it? Because remember, you're sad, deep despair, you feel like you're hopeless at this point. I don't know anything about my future right now because I'm just so depressed. I just don't think living is the right way to go. You know, okay, well, I feel very bad that you feel that way. Did you have a plan of what you wanted to do to hurt yourself? And if they say no, I don't have any plan. I just don't want to be alive right now. All right. So now we know they don't have a plan. So right now they're really looking for someone to talk to. So have that conversation. Get them to go talk to a professional. Do not sign these patients off. Right? They need to go. They need to be seen. Some risk factors for suicide, obviously, is depression at any age and feeling trapped or purposeless. Previous suicide attempt, about 80% of successful suicides were preceded by by at least one prior attempt. Current expression of wanting to commit suicide or a sense of hopelessness, specific plan, family history of suicide, people older than 40 years, particularly if single, widowed, divorced, alcoholic, or depressed. Men who are older than 55 years have especially high risk and are very often successful if they make an attempt. Recent loss of a spouse, significant other, family member, or support system. Chronic debilitating illnesses or recent diagnosis of a serious illness. Feeling anxious, agitated, angry, reckless, or aggressive. Also dramatic mood changes such as from depression to agitation. Financial setback, loss of job, police arrest, imprisonment, or some sort of social embarrassment. Alcohol or substance abuse. Children of an alcoholic or abusive parent. Withdrawal from a family or friends or lack of social support resulting in isolation. Significant anniversaries of sentinel events. Unusual collection or acquisition of things that can cause death, such as a gun or a large volume of pills. So you want to consider the additional risks. Are there any unsafe objects nearby? Is the environment unsafe? Is there evidence of self-destructive behavior? And is there an imminent threat to the patient or others? If there is, these patients need to be transported, because there's definitely an imminent threat. Is there an underlying medical problem? Are there cultural or religious beliefs prompting the suicide? Has there been any trauma? So a suicidal patient may be homicidal as well. So they'll call SIHI, so homicidal ideations and suicidal ideations. So if they're suicidal and they say, yeah, I want to die, but I want to take this person out with me, they have a plan to kill this person. So this happened in a town where one guy was, I don't have the whole story completely straight. I'm just going to kind of paraphrase this. Two people screwing around, male and female. Boyfriend or husband found out about it, went there and shot them both. And then I believe he shot himself afterwards. So again, he had a plan for suicide and he was homicidal. Went in there, did what he had to do, killed one, the other one lived, and then he shot himself. Okay, so you got to be careful with that, the suicidal and homicidal plans. And if they're willing to tell you what the plan is, find out what the plan is and pass it along. PTSD occurs after exposure to or injury from a traumatic event. So some events would be sexual or physical assault, child abuse, or any kind of serious accident. Some example events would be natural disasters, war, loss of a loved one, or stressful life changes. So you got to kind of pay attention for those. So an estimated 7 to 8% of general population will experience PTSD at some point in time in their lives. Military personnel with combat experience have a high incidence of this happening. Symptoms of PTSD also include feelings of helplessness, anxiety, anger, and fear. A lot of times patients with PTSD, some of the best first aid provide is psychological, and just having a chance to talk with them and just kind of go over, what are they thinking, what's going on, Have them talk about the incident that's currently happening with them and trying to work them through it all. Sometimes people that have PTSD also have people they can contact themselves, people that they know who they are as well, and they can have those conversations also. May avoid reminders of the trauma, loud noises or smells or interactions with people. It's interesting how PTSD works because, I mean, obviously they could be walking down the road and have a smell and it could trigger something from the war that they were in or whatnot. They can suffer constant nervous system arousals. They can also relive the traumatic event through thoughts, nightmares, and flashbacks. When I was doing my clinical time for my medic years ago, one of the things we had to do was time in nursing homes. And there were a lot of patients that had dementia that were war veterans. And it was interesting of some of the things that they would actually do when they started having, when they were going into a flashback of some sort and relive different events. I've seen one of the patients that we dealt with used to flip his bed over and pretend it was a bunker. And he had started throwing things like they were grenades trying to save themselves. So yeah, it was interesting to see this kind of stuff, and it really put a big perspective with that. So combat veterans are prone to early heart disease, higher incidence of type 2 diabetes, loss of brain gray matter, and high incidence of TBI as well. Caring for the combat vet requires a unique level of understanding, so be careful how you phrase your questions. Use a calm, firm voice, but be in charge of the situation. Respect a veteran's personal space. Limit the number of people involved and ask about suicidal intentions or suicidal ideations. Make sure your partner is also there with you as well, but you want to limit the amount of number of people that are around these people. Because sometimes they can feel like they're becoming claustrophobic because there's so many people in the room that can make them uncomfortable. And that's something that you don't want to happen. You want to make sure that they can stay calm. Ensure that there is nothing the patient can access or use as a weapon. Remember, they were combat trained. Even if they're 70 years old, 60 years old, let's say if they're throwing out age numbers here, again, they were still combat trained and they have flashbacks back when they were. Physical restraints may simply escalate the problem. They don't want to be imprisoned, right? Especially if they are prisoners of war and they somehow got out. So just kind of keep this kind of stuff in the back of your head. So some medical legal considerations of aspects of EMS are more complicated with patients undergoing behavioral crises or psychiatric emergencies. The legal problems are reduced when the patient can sense the care. So gaining the patient's confidence is critical, right? Because if you start saying this patient is no longer competent because you ask them, person, place, time, and event, they don't know where they are, they don't know what's going on, they're threatening to hurt themselves, we are now taking away their rights to be able to make decisions. And we are using implied consent to take care of this patient, because if he was in the right state of mind, the patient would say, please help me, right? So we contact medical control. We say this patient is not alert, not oriented. He's got a psychological emergency going on. He needs to come to the hospital. Law enforcement is here. They all agree. The patient's been IEA'd. They've got to go to the hospital. At this point in time, we're saying this guy here is going. We have to make that determination. And we have to find a way to get him onto the stretcher, hopefully by gaining the patient's confidence and getting him to sit down. But if not, it could turn into something physical. We're trying to stay away from the physical side. As much as it is a rough house of people, it can be fun. We don't want to do that, because if we hurt the patient in the process, we can get in trouble for that, right? It can be reported. So again, gain the patient's confidence. That's very crucial from the beginning, all right? And get these patients to go to the ER. You must decide whether the patient needs immediate emergency medical care. The patient may resist your attempt to provide care. Again, the main purpose is to get this patient to the hospital. So they may say, I'll go, but you can't touch me. All right, that's fine. Document in your narratives, patient refused vital signs, any kind of assessment, and things like that. But you know what? He still got the definitive care of the hospital. We do the best we can to make that happen. If we need law enforcement personnel to handle the patient, then make that request. Remember, with consent, like I mentioned before, implied consent is assumed with a patient who is not mentally competent to grant consent. Consent matters are not always clear-cut in psychiatric emergencies. So if you're not sure, request the assistance of law enforcement personnel or guidance from medical control. There's nothing wrong with talking to a physician. They are there to consult, and they're going to give you the orders that need to happen. So have that consultation, let them know what's going on. Limited legal authority. So the EMT has limited legal authority to require a patient to undergo emergency medical care when no life-threatening emergency exists. Competent adults have the right to refuse care. In psychiatric cases, a court of law would probably consider your actions in providing life-saving care to be appropriate, but a patient who is in any way impaired may not be considered competent. So maintain a high index of suspicion about the patient's condition and err on the side of treatment and transport before you start saying the patient does not need to go to the hospital. Again, a lot of the stuff that's going on with this kind of stuff with these patients, watch the train of thought. Documentation is, I remember now, documentation is going to be key for this because remember, if there is a type of issue that does have to go to the court of law, again, they're going to look at your narrative because let's say you forcefully put this patient on the stretcher and the patient didn't want to go and they were deemed that they were not incompetent and they could make decisions. Your documentation in your narrative and the way you do assessments is going to save you for what you've done. Right. That's why it's so important to make sure you document appropriately and everything that would happen, including full assessments. And with a person like myself who does quality assurance on these patients on run reports, I see a lot of times where they don't fully document what's going on. And I ask them, what would happen if this went to court? Oh, well, I mean, I did it. I just didn't put it down in my narrative. Then it never happened. Right. So that's why it's so important to provide appropriate documentation because this court case, if you were to go, could happen 4 years down the road. And you've probably done about 2,000 calls since then. Like you actually remember that type of call, what exactly happened. And they'll also bring up other patient care stuff as well from you that you've done to see your process and how things work. If you're consistent with an assessment. All right. So a behavioral crisis is most accurately defined as A or B. Anybody still there? There we go. There's some popping up. So I heard a B. I have one response. There's two responses. Oh, I should have showed you C and D. I didn't know those. I can't see the other slides beyond that. That's C and D. All right, so the answer is B. Great job. Number 2. So depression and schizophrenia are examples of what?
C.
So I'm seeing C's. I may have seen an A. A. All right, A. So unlike organic disorders, a functional disorder cannot be linked to any physical dysfunction or a failure to an organ. Depression, schizophrenia, obsessive compulsive disorder, OCD, and bipolar disorders are examples of functional disorders. So when assessing a patient with a behavioral crisis, your primary concern must be what? All right, seeing B's and D's. All right, the answer is D. There are many things that you should be concerned with when assessing a patient behavioral crisis, including all the items listed as answers to this question. But your primary concern must be the safety of yourself and your partner. Again, a lot of right answers, but which one's more right than the others? And that's going to be like the National Registry. General guidelines to follow when caring for a patient with a behavioral crisis include all the following except.
B. B.
B it is. Nice. Reflective listening, an assessment technique used when caring for patients with emotional crisis, involve what?
I said D.
All right. D it is. Reflective listening, technique in which you repeat in a question form. Which of the following patients is at highest risk for suicide?
C. Or D.
All right, we got C. So situations or indications that place a person at high risk for suicide include, but not limited to, recent diagnosis of a serious illness, financial setback, marital discord, death of a loved one, untreated psychiatric illness, recent acquisition of items that can cause death, such as a gun or knife, and or chronic alcohol abuse. Number 7. So when caring for a patient with an emotional crisis who is calm and not in need of immediate emergency care, your best course of action is to do what?
C. B.
C it is. All right, so number 8. When physically restraining a violent patient, the EMT should do what?
A.
A it is. Nice work. Number 9. So upon arrival at a residence of a young male with an apparent emotional crisis, a police officer tells you that the man is acting bizarre. You find him sitting on his couch. He is conscious but confused. He takes medications but cannot remember why. His skin is pale and diaphoretic. He has noticeable tremors to his hands. What should you first rule out? That was a lot of A's. I like it. A it is. Rule out diabetes first, hypoglycemia. And number 10. Which of the following signs is least indicative of a patient's potential for violence?
B.
B it is. All right. Almost 9 o'clock. There's no way that we're going to be able to get another chapter in and be done by 10. So I'm going to stop recording here and we have a quick discussion before we